Thank you very much. So, good afternoon, everyone. Just a couple of things about me. I am an advanced trainee at the Alfred, so I feel a little bit underqualified to try and teach all the experienced clinicians in the room, especially my director who told me he wasn't going to be here, about how to do a ward round. And with that, I just did want to mention I'm a conference speaking virgin. So if we could keep the heckling, leaving in disgust and falling asleep from boredom to a minimum, my ego would really greatly appreciate it. I thank you all so much for coming along today. I know it's just a slightly unsexy topic for us to talk about, but the ward round is a huge part of what we do in ICU. Renal physicians look after patients who are on dialysis. Cardiologists, they look after patients who've had heart attacks. And intensivists, we do ward rounds. So we should really be very good at them, and we should look at how we do them. In the words of the 45th President of the United States, I want you to come on a journey with me this afternoon to make ward rounds great again. When I started looking at this topic and delving into it, I think the best place to start and explain about what we can do to change them is look at the old who, what, when, where, why and how. And I'm going to start with why, because I think it's the most important. There really are two whys. The first why is, why do we do the ward round? At its core, the purpose of the ward round is simple. It is to focus your undivided attention on one patient for a period of time to optimise their care. But as we all know, this gets completely obscured by all of the roles, responsibilities, interruptions, time constraints, and just often the pure chaos of the ICU unit. And this brings me to the second why. Why is it so hard to get right? This paper is a paper by Lane and Co, and they delved deep into the research of the ICU ward round in 2013 and produced a review report, and they looked at the factors that facilitate and are barriers to an effective ICU ward round. And a lot of the information I'm going to present to you is from this paper today and the derivatives of it. So what are the interruptions? What are the barriers, I should say? The interruptions, they're the hugest barrier that I think we can all readily identify. But no matter what, they're hard to reduce. Increased rounding time is a barrier to providing an effective ward round. Some Canadian group looked at 111 ICUs and found a median ward round time for each patient of 15 minutes. Seems pretty standard. I think that's probably how long I take for a ward round. Long time when you compare it to the 2 minutes and 30 seconds that it takes our surgical colleagues to do a ward round, and even the 9 to 10 minutes that the British Royal Physician Society recommends that their practitioners do their ward rounds for. Other things that can be barriers include using a non-standardised structure, poor documentation, maintaining a hierarchical healthcare practitioner structure, having your allied health and nursing staff not feeling valued by the medical staff. So this will lead to poor communication and poor collaboration. And the final one down the bottom, which I think we're going to explore in the next couple of talks, is electronic health record use. So it reduces visibility and reduces staff participation in the ward round. But I think that we need to work on this very hard over the next few years because it's becoming ubiquitous. And hopefully we can explore it a bit later. So who should be in your ward round dream team? You only have to spend about 5 minutes with me, which is probably how long I've been talking about, and you'll know that I love gin. If you don't know things about gin, I'm going to give you a quick little tips. So gin is made up of anywhere between half a dozen to a dozen botanicals, but the most important is juniper, because gin is a juniper-based spirit. You have to have juniper. The next most common, which is up over here, is coriander seeds, and that is in almost every gin. All the other botanicals can be mixed and matched and changed to suit the kind of blend and taste of the gin that you want. And I think this is just like the ward round, because I relate everything to gin. So the ward round is a patient-based activity. So the patient must be the centre and the most flavourful bit of the ward round. The coriander seeds, somewhat like the consultant, they're there the most of the time. And all of the other botanicals can be mixed and matched and changed to suit your ICU and what you want to get out of your ward round. Just going to change tact a little and talk about this guy. I've never met him, but I've learnt a lot from him. This is a medical student by the name of Ben, and some of you may have seen him before. About 5 years ago, Ben had bowel cancer. And if you haven't read this article already, I highly recommend it. This is an article he wrote for the ABC. He's written quite a lot. And in this one, he gives wonderful insights to the patient's perspective of the ward round. He's mostly commenting on surgical ward rounds, but I think that there's things that we can learn. So he talks about the hospital being the doctor's workplace and that he's a visitor. And that's a topic that's already come up in this conference. He talks about being woken by a room full of strangers, about people talking at him and not to him. And although many of our patients aren't in a place to participate in our ward round, some are. And I think that we're missing that group. The patients I'm most concerned about for some of our ward rounds are our long stay patients. At day 35, day 40, we may not need to give that patient their allocated 15 minutes of time to work out all of their medical problems and form a plan for the day. But maybe that extra time we should sit down next to them, talk to them, make sure they understand what's going on, make sure that they contribute to their plan and they express how they're feeling about their healthcare and how their journey is going within the ICU. So who? Continuing on, the guys from Scrubs, they knew it. A multidisciplinary ward round is the way to go. If you haven't watched a lot of Scrubs, I'm not quite sure why the janitor was in their ward round, but that's okay. Multidisciplinary means medical staff plus at least one other healthcare practitioner. So just the simple act of having a nursing staff member on your ward round has shown to improve patient outcomes, improve nursing staff satisfaction, and lead to a more goal-orientated and patient prognosis-related discussions on your ward round. If you take it a step further and you add a pharmacist to your ward round, there's even greater bang for your buck. They've been found to show reduction in adverse drug events by 66%. So clearly that's going to result in cost savings and clinical benefits. Where should you hold your ward round? Unfortunately, the evidence out there is not all that helpful and it's conflicting. Bedside locations will allow better family and nursing staff communication and satisfaction, but they lead to increased distraction, increased interruptions and ultimately increased rounding time, which we know leads to worse outcomes and is a barrier to good effective ward rounds. Whereas conducting the ward round away from the bedside leads to shorter rounding time, better communication and better interaction between healthcare professionals. So what is the optimal ward round? Is maybe a split ward round the way to go, starting with some information gathering at the bedside and then moving away for a multidisciplinary discussion at a remote location, or maybe vice versa. And this may be something that you're going to have to tailor for your department. But I think with increasing EMR use, this is really something that we should be able to focus on and hone in and improve. When should we do the ward round? I personally benefit from routine and structure. And I think the ward round is no different. It's been shown that regular times, even a formal rounding schedule, has been shown to improve participation, engagement, and the length of rounds. If anywhere in the talk yesterday talking about using text messages, I wonder whether, this is something that I've thought about over the last 24 hours, is family involvement in the ward round. We've also been speaking about that at the conference, and whether a text message to the family members of the patient going, the ward round is going to be at your loved one's bedside at 10:10. Please present if you would like to participate in the ward round. It can be as simple as that. Family participation in the ward round isn't something that I'm going to cover a lot in this talk due to time constraints, but we may be able to explore it further in the discussion time. So what things can we do and can we implement into our ward rounds to make them better? So we can optimise our health record use and documentation. Make sure everyone has the access to the patient data. Make sure everyone can see the patient data. Enhance information exchange by providing a visual summary so that all participants in the ward round know the same information. Improve communication strategies, and this can be done by implementing standardised rounding times so that people know when the round is happening and they know when they can come and participate. Also, creating explicit definitions for the role of the healthcare providers that are on the ward round helps improve their communication because they know what their role and their input is meant to be. Encourage communication and collaborative decision making. And I've mentioned this already, but reducing the hierarchical system of your ward round allows greater healthcare practitioner autonomy and speaking up. Keep the ward round to goal-orientated discussions, and not only have the discussions and make the goals, but follow up at the end of the day and work out what goals are being completed. I think intensivists come in one of two flavours. They either love checklists or they hate checklists. And whilst checklists haven't been shown to have a mortality benefit, they have been shown to improve the understanding of goals of care. They've been shown to improve communication, adherence to practice guidelines, and increase provider satisfaction. And I know that when I tick off all the things on that checklist, I feel pretty satisfied. The last one that that might be used is to reduce non-essential activities. And the literature says that education is a non-essential activity. I'm not sure about this. I think that education on the ward round is one of its main artillery, and that not educating on a ward round is false economy. But maybe keeping to one education point per patient is a good compromise. So how do we know that we're doing any good? I'm not going to talk to you all about the audit cycle because I would hope that you all know what it is. But you need to enter the audit cycle. You need to make changes and make ward round improvement a priority in your unit. So I just want to recap. These are just the final recommendations by the systematic review that Lane did in 2013 in looking at the levels of evidence. These are the definitely do it. So make your ward round multidisciplinary. Standardise the location, the time and your team composition. Make sure your nursing staff are there. Make sure you're getting a pharmacist on your ward round. Define explicit roles for each practitioner on the ward round. Use a checklist. Minimise the interruptions as much as you possibly can. It's very difficult, I know. And focus your discussions on development of daily goals. And the probably do-its are the open collaborative environment and the hierarchical structure. Ensuring clear visibility. So this might mean restructuring the actual physics of your ward round. Are people in a nice semicircle? Do they have clear lights, sight lines? Can they see each other easily? And that's going to encourage them to speak up. Promote team-based discussions and have a visual representation of what the patient's issues are. So thank you so much for listening to me today. I hope my talk has been more inspiring than this guy.